So the next two presenters coming from Murdoch Children's Research Hospital in Victoria, Dr. Amanda Gwee and her PhD student Amanda Wilkins. Amanda Gwee is a clinician scientist in the infectious diseases and microbiology group. She's a general paediatrician, infectious diseases physician, and clinical pharmacologist at the Royal Children's Hospital in Melbourne. She's also an associate professor in the Department of Paediatrics at the University of Melbourne. And she's going to talk to us about antimicrobial optimisation in neonates. And following on from her, we've got Amanda Wilkins. She's recently completed her training as a general paediatrician and is completing her clinical pharmacology training at the Royal Children's Hospital in Melbourne. So I'm going to pass over to the two Amandas now.
Thanks for inviting us to speak on antimicrobial optimisation in neonates. Firstly, why is antimicrobial optimisation important in neonates? We know that infections account for 1/4 of deaths during the neonatal period, and we know that neonates in particular have really high rates of antibiotic exposure, with a study showing that low birth weight neonates receive 17 drug courses per admission, with 1/4 of them being for antibiotics. There are numerous challenges to antibiotic dosing during the neonatal period, which Nicola has already touched on, and they include maturation of organ function, the variability in the dosing recommendations across different drug formularies, and then thirdly, the lack of high quality pharmacokinetic and pharmacodynamic studies. In terms of maturation of organ function, you may have seen this diagram before, but basically the neonatal period is a time of rapid maturation in a variety of different functions. Firstly, in terms of bioavailability, you see maturation in gastrointestinal absorption, and the absorption of drugs is affected by a variety of factors, such as neonates having lower gastric pH, slower gastric emptying, slower intestinal motility, and it's also affected by the type of milk the infant's receiving, as well as development of the CYP enzymes and the P-glycoprotein efflux pumps. We always have this belief that neonates have poorer bioavailability of antibiotics compared to adults, but there was a systematic review published in 2019 that included some of the first-line antibiotics that we use in neonates, such as ampicillin, amoxicillin, and flucloxacillin. And surprisingly, the bioavailability in neonates of these drugs were very similar to adults, but these studies were very small and we do need more data on it. But this is very reassuring data and does suggest that we should be looking at whether or not we could treat infections more commonly with oral antibiotics in this population. In terms of body surface area, we know that neonates have the highest body surface area to weight ratio, which then reduces throughout childhood into adulthood. And there's also maturation in liver metabolism during pregnancy and during the neonatal period. So there's 3 classes of liver enzymes. Class 1, which includes CYP3A7, you have the highest level in the fetus and during the first trimester. And class 2, you tend to have constant levels throughout gestation through to adulthood. And then class 3, which represents the majority of enzymes involved in drug metabolism, you have 30 to 60% of adult values at birth, and then it reaches full activity at around 2 years of age. And this is particularly important for drugs such as metronidazole, which is metabolized to an active metabolite, and macrolides such as clarithromycin, which is metabolized through CYP3A4. And then finally, you have acquisition of renal function. And one of the major limitations to us giving renally cleared drugs in neonates is the fact that we don't have a reliable creatinine clearance calculator, such as the Schwartz equation is shown to predict poorly in neonates. We know that maturation of glomerular filtration is described using postmenstrual age, and it reaches approximately 50% of adult values at 8 weeks, at 48 weeks postmenstrual age. So the second issue is around the significant variability in dosing, and there was an excellent review article published in 2018 which highlighted how much we don't know about neonatal dosing. So this is a review that looked at the dosing recommendations for all the commonly used antibiotics in neonates and compared the dosing recommendations across 8 different formularies. And here I've just chosen ampicillin, cefotaxime and gentamicin because they're the first-line antibiotics that we would use in neonates. And you can see that the range of doses ranges 4-fold to up to 6-fold here for neonates of the same postnatal age and weight, which is just astonishing actually, and just shows that we really don't know what we're doing in the neonatal population. There's also been just a lack of high quality pharmacokinetic and pharmacodynamic studies, and you may have seen this before, but there is a real lack of good pharmacokinetic studies, even for the first-line antibiotics that we use in neonates. So here I've used a traffic light system where amber is less than 5 studies, green is 5 or more studies. And you can see for these very common, sorry, I've spelled cefazoline incorrectly, there are very few studies for ampicillin, flucloxacillin and cefotaxime. And then if you look at pharmacodynamic studies, there are no pharmacodynamic studies, and I could only find a single study for gentamicin. So this is an area that Nicolette was just referring to, that we definitely need more data and dedicated data specifically in neonates. So for many drugs, we can use the pharmacodynamic targets from the adult literature, and this is a summary table similar to what Nicolette just showed, looking at the different antibiotic groups and outlining the pharmacodynamic targets in mild to moderate compared to severe infection, and also it outlines the predictors of clearance in neonates for different drug classes. It's a very useful resource for neonatal dosing. But what's important to know is that there are no pharmacodynamic studies on listeria, which is a common pathogen in neonates, but very uncommon outside of the neonatal period. And there's very little data on coagulase negative staphylococci, which is one of the most common causes of late onset sepsis. So I thought I'd briefly touch on some of the pharmacodynamic studies, and then Amanda Wilkins will be talking about the pharmacokinetic studies. In terms of the pharmacodynamic studies, there is one pharmacodynamic study looking at the in vitro, that used in vitro static and dynamic kill curves for E. coli, then used a semi-mechanistic PK/PD model. And this study found that in term newborns, the dose of 4 milligram per kilo every 24 hours was most effective, and they defined effectiveness as having a bacterial load lower than the starting inoculum for the infection. And for preterm newborns, even though they had lower peak concentrations, they had higher bacterial killing. And this, again, highlights, similar to the adult literature, the importance of area under the concentration time curve as the pharmacodynamic target above the peak concentration. Now, in terms of vancomycin for coagulase negative staphylococci, I was going to run you through the studies that have been published on this. Firstly, there was an in vivo neutropenic murine model of foreign body and systemic infection with methicillin-resistant staph epidermidis. And this was a study comparing vancomycin to ceftaroline. And for those mice that received vancomycin, there was a lower mortality observed in those that had a higher vancomycin area under the curve to MIC ratio. But this difference was not found to be significant. Then there was a hollow fibre and rabbit model of neonatal coagulase negative staphylococcal bloodstream infection. And this study used 5 different strains, 3 of staph epidermidis and 2 of staph capitis. And they found that maximum bacterial killing and prevention of resistance was associated with an area under the curve to MIC ratio of greater than 665 in the hollow fibre model and 520 in the rabbit model. But the MICs of these bacteria were 2, which means the target area under the curve over a 24-hour period would be over 1,000. And we know that from data and a systematic review done in adults that would be way above the toxicodynamic, the AUC target for which we see increased renal toxicity. Following that, there was then a large retrospective clinical study done that used data from 785 children with suspected gram-positive infections, of which 102 had confirmed gram-positive bacteremia. And this study was unable to show a clear relationship between vancomycin exposure, vancomycin MIC, and clinical efficacy. And the authors suggested that the reason why they were unable to find a relationship was because of the potential inclusion of contaminant specimens, which, and as we know, coagulase negative staphylococci are common contaminants in blood cultures. So I'm just going to present the data from one of our studies that is currently in press, not yet published, but we did a study looking at vancomycin pharmacodynamics for staphylococci at the Children's Hospital, and we retrospectively identified 30 young infants aged 0 to 90 days who had either a single positive blood culture with MRSA or 2 separate positive blood cultures with the same coagulase negative staphylococcal species. And of these, 3/4 of the babies had a central venous catheter in situ, and 1/4 of them had them removed or replaced during the treatment course. And of the isolates, 28 were coagulase negative staphylococci and 2 were MRSA. We then took the isolates from these episodes of bacteremia and determined the vancomycin MIC using a broth microdilution method. We only got one of the MRSA isolates, and the vancomycin MIC was 1. And for coagulase negative staph, the median MIC was 1, but the MICs range between 0.5 to 4. Then we used the current study data set to externally evaluate our vancomycin pharmacokinetic model that we had already published, and we found that the model adequately described the current data set. And then with the PK model, we then built a PD model using a parametric time to event model. And we define the event, as we do in clinical practice, as being the first negative blood culture, with the time to event being the time from the first positive to the first negative blood culture. And in this study, we found that an area under the curve in the first 24 hours of treatment of 300 or more is associated with 7.8 times increase in bacteriological cure, and an area under the curve at between 24 to 48 hours of greater than 424 is associated with a 7.3 times increase in bacteriological cure. So very similar to the targets for MRSA, which is good to know actually, so that we don't have to target different concentrations. So that's it for the PD data, and I'm now going to hand over to Amanda Wilkins to present some of the PK studies in neonates.
Thanks very much, Amanda. I'll just share my screen. Perfect. Does that look okay for everyone?
Yep, that's spot on, Amanda.
Great, thanks, Susie. So I'm going to carry on from Amanda's talk and focus on pharmacokinetics of antibiotics in neonates. And thank you very much to the host for the opportunity to talk tonight. The specific examples that I'll use are vancomycin and fosfomycin. There's also a lot of data in neonates, PK data for meropenem from the neo-mero group, but we haven't chosen to talk about that tonight. It was presented previously at another presentation. So I'll talk first about vancomycin, and as Amanda has already spoken about, there's many challenges to vanc use in young infants, and she's described challenges related to maturation of organ function and the lack of data on appropriate PD targets. So I'll talk a bit now about the lack of data for neonates with severe disease. So there's been numerous PK studies in neonates as a group, including premature neonates. However, the subpopulations who have severe disease and require interventions like ECMO or various other pharmacological interventions are often not studied, and we have a lack of data in those groups. I'll also talk a bit about limitations to TDM and also the fact that there's no consensus on vancomycin dosing guidelines. So there's a lack of data for these neonates with severe disease, and I've picked 2 examples. One, neonates who require ECMO, and the other is neonates requiring indomethacin or ibuprofen for their congenital heart disease. So I guess a lot of these neonates are left out of the general PK studies, and there's only been 6 PK studies that have looked at vanc PK in infants on ECMO. And these are children with cardiac or respiratory failure who are often at high risk of sepsis and commonly on antibiotics like vancomycin. And so there's a real need to make sure that we're adequately dosing them. Of the 6 PK studies that have already been published, half of these were actually done 30 years ago in the 90s, and they had quite small study populations. They didn't have control groups. And there's also, I guess, now comments about the fact that the ECMO circuits that we used back then are a lot different to the ECMO circuits that are used now, and therefore their impact on drug clearance and drug PK would be different. I've just brought here this table from a publication from Anne and colleagues last year. This was a study they did, a retrospective study that compared 25 term neonates on ECMO and another 25 neonates who did not have ECMO. And they developed a PK model and were able to describe that the clearance in the ECMO group was significantly reduced compared to their clearance in the non-ECMO group. They also showed a prolonged half-life and also higher trough concentrations in the ECMO group. They showed no difference in volume of distribution between the two groups, which compared to some of the historical data is inconsistent with what's previously been described. But we can see that there's a difference in the PK profile for VANC in children in ECMO, and therefore likely different dosing requirements for them. I've also just here given some details from the SIZE study that was published in 2017. This study had a smaller number of neonates, but it included some late preterm neonates. And they interestingly had a much higher clearance in their PK model. And they compared it to all the previous studies in this nice summary table down the bottom. And we're actually able to show that their clearance was up to 3 times higher than the clearance reported previously. And they attributed that to the fact that the ECMO circuits now are quite different to what they were back then, as a possible explanation. But there were also differences with their values in volume of distribution and half-life too. And I guess the other confounding factor is the comorbidities now and other medications used and things that would impact VANC PK are also different to what they would have been when the previous studies were published. The other example of neonates where we've got a lack of data in for PK studies are those with congenital heart disease. And one of the common conditions we see in premature neonates is patent ductus arteriosus. And without going into details about the condition, it's previously not been uncommon that these neonates would be treated with indomethacin or ibuprofen. And there's been a number of studies that have looked at the impact of these medications on VANC clearance, given their impact on renal function. And this figure nicely shows, with the red line at the top being children on vancomycin and indomethacin, and then the purple line, children on vancomycin and ibuprofen, and then the line at the bottom, children on neither agents, to show that actually indomethacin significantly impacts vancomycin clearance by up to 55% in one study, and that ibuprofen also poses some reduction in VANC clearance as well. So from this, we can see that there's limited data across various subgroups of neonates with severe disease, and that more data is required for us to be able to dose these neonates appropriately. The next challenge to vancomycin use in young infants is limitation to therapeutic drug monitoring. So a lot of the neonates now we're seeing in the intensive care units are premature neonates, and serial blood testing already contributes to their risk of anemia and need for blood transfusions, and that's contributed to by TDM for drugs like vancomycin and gentamicin. And so trying to optimise TDM use in these infants is really important. One of the strategies, I guess, is using early therapeutic drug monitoring in order to then do an early dose adjustment and reach target exposures sooner. And doing that would hopefully mean fewer TDM levels required to be taken as the treatment course continues. Unfortunately, there's not been any studies looking primarily at neonates with early therapeutic drug monitoring, meaning kind of around the first dose and then early dose adjustment. But I've just here on the table put 2 studies that were published in the last couple of years in paediatrics, and they included infants down to 1 month of age. The first study by Lim and colleagues was a retrospective study where they compared children who were on intermittent vancomycin dosing, who either had their TDM done at steady state or they had first dose TDM and then a PK online program was used to dose adjust. And they didn't show any difference in their primary outcome of time to attainment of the target trough level. Both groups took around 36 hours to achieve a target trough of 10 to 20. Another excellent study that was done in 2019, which included children down to 3 months of age, was a prospective RCT, and they looked at children on continuous vanc infusions and compared early therapeutic drug monitoring at 3 hours and then beige and dose adjustment implemented at 6 hours. And their primary outcome was looking at AUC to MIC of 400 to 800 at 24 hours. And they did show a significant difference with a higher proportion in the early TDM group achieving their target AUC. So I think there's definitely space in the neonatal arena for early TDM assessment to see if this would be something where we could achieve earlier target exposures in this population. The last thing to talk about with challenges to vanc use is that, similar to what Amanda's already spoken about, that there's a lack of consensus on vanc dosing guidelines in neonates. So this table, formatted differently, but very similar to the one Amanda showed, shows about 8 of the dosing guidelines for vancomycin that are used internationally. And so all empiric intermittent vanc dosing is in milligrams per kilo, ranging somewhere between 10 to 20 milligrams per kilo per dose. And the dosing interval is dictated by different covariates depending on the guideline. And so the one highlighted now is NeoFACS, which is the US dosing guidelines. And their dosing interval is dictated by postmenstrual age, so age since conception, and also postnatal age, so the number of days since birth. Versus the British National Formulae is interval based on postmenstrual age alone, and then say Red Book dosing, which is based on renal function. And given all these guidelines, there's been numerous studies to look at the performance for them in achieving target exposures. And this table, we've just pulled a few papers that looked at the performance of these guidelines. And so British National Formulae, the NeoFACS, and also the Dutch Paediatric Formulae, all of those had less than 50% of the neonates in their studies achieving therapeutic range at first steady state level. So clearly we're not enabling neonates to reach target exposures required to treat these serious kind of life-threatening infections that they're having. I guess the only thing to note, so the therapeutic range in some of these studies is different. So the Dutch Paediatric Formulae used a range of 10 to 15, for which some of the children in that study that would have been considered supratherapeutic may have actually been within the target range of 10 to 20 if they had levels between 15 to 20 in that study. Of the children who weren't in target range, the majority of these were subtherapeutic. So I guess the message is that we're likely to be underdosing a lot of our neonates and certainly not achieving target exposures. The last dosing guideline on that table is the Dutch Paediatric Formulae, and it was a study that assessed their dosing guidelines after 2015, which is when they changed to a dosing guideline that was based on a recent POP-PK model. And this actually showed that this empiric intermittent dosing guideline didn't achieve that many more neonates reaching target exposure than the previous guideline. And I guess the whole picture that this is painting is that we're not accounting for a lot of the variability in patients when we're dosing them. So there's a huge between subject variability in vancomycin, and that just can't be accounted for when we're doing empiric dosing. And so that leads me then to just talk a bit about the opportunity for individualised dosing in neonates, where we've got this big between subject variability. And there have been a few studies that have looked at model-informed individualised dosing for vancomycin in neonates and young infants. And this looks like a really promising area, and it's where my research with Amanda Gwee is. So there have been 2 prospective studies that have looked at continuous infusion vancomycin individualised dosing, so that's Zal and Leroux. And then there's been one study that has retrospectively looked at an intermittent online individualised dosing calculator. So the 2 studies that looked at continuous infusion were actually looking at the same dosing calculator. So this was a dosing calculator formatted in Excel, and the model that the calculator was based on was prospective data from 116 neonates. And the Excel calculator allowed the user to put in the child's birth weight, their current weight, their postnatal age, and a serum creatinine, as well as their target concentration. And it generated a loading dose as well as the maintenance continuous infusion dose. So Zhao in the paper in 2013 published the POP-PK model this was based on, and they also reported on a clinical validation cohort of 58 neonates that use this calculator. And their results showed that 70% of those neonates achieved a vancomycin concentration of 15 to 25, which was their target concentration at the first TDM level. Interestingly, they used their first TDM level was taken at 6 to 12 hours, which is likely, I guess, to have been early for a steady state level in some of those. They didn't comment kind of on that earlier timeframe they used. And then to further clinically validate that same Excel calculator, Leroux published a prospective multi-centre study this time across 3 centres with just under 200 neonates. And this showed really similar results with 72% of those neonates achieving the target concentration. And the calculator dosing proved to have a good safety profile, with 2 neonates having nephrotoxicity, but neither felt to be related to the vancomycin itself. And then just lastly, there was a paper published by Freumeyer, which was a retrospective paper that looked at an online dosing calculator called NeoVanco. And that calculator online provides a table based on the child's characteristics with dosing recommendations and what concentration, trough concentration, or what AUC that the calculator predicts the child would reach given those different dosing options. And so this study showed that 41.5% of those neonates achieved a concentration of 10 to 20 at first TDM level if they used the calculator. And when they looked at how many would achieve an AUC target greater than 400, it was increased a bit to 63%. So certainly results that look like they're improving upon the target attainment we saw with empiric dosing on the table before. So just quickly to present some data that we have from a recent study, a multi-centre study in Victoria and New South Wales. My PhD project is looking at individualised model-informed intermittent dosing in neonates. And we've done a prospective cohort study to assess an online calculator. So this is just an image that shows our online calculator. And the study that we did was called VanCap using this calculator. And it's a calculator that's based on a published POP-PK model that Amanda Gwee and colleagues constructed. It was based on prospectively collected data from a multi-centre randomised control study, and they had 104 infants. And from that model, this calculator was derived. And so the online calculator allows you to put the baby's post-menstrual age, their weight, creatinine, and a target trough level. And you can see on the screen to the right doses given, as well as a total daily dose. So we validated this modelling calculator in a multi-centre prospective study. We did it across 4 sites this time to ensure that we could prove that the modelling calculator was generalisable in external populations. And so we had 40 young infants that we recruited who used the calculator for their vancomycin dosing. And at first steady state trough level, which was around 24 hours for almost all infants, we had 75% of the population achieving a target trough of 10 to 20. Given the IDSA guidelines around AUC being a superior exposure target, we also looked at that, and we found that 80% of our participants had achieved an AUC between 400 and 650. So this data is just currently manuscript underway and hopefully to be published soon. Lastly, I've just got a couple of slides on fosfomycin. So fosfomycin is interesting. It's not an antibiotic that's commonly used in neonates at all. In fact, it's more commonly seen used in adults for urinary tract infections. And usually for our gram-negative infections in neonates, gentamicin or cefotaxime would be used. But as Nicolette showed in her slide, there's rising resistance to many bacteria, including gram-negative bacteria to gentamicin. And fosfomycin would be a possible alternative, which could be effective against these multi-drug resistant organisms, and also has the benefit of being an oral agent. So there hasn't been much data at all on fosfomycin PK. So most of the data is adult data. It's published over 30 years ago with small sample sizes. And there hasn't been any neonatal studies up until now. So just earlier this year, the NeoPhosPho study was published. And so this is the first neonatal pop PK model, and they were able to describe the PK parameters, and particularly importantly, the bioavailability for this drug that can be used orally. And so their study was a randomized control study that was done in Kenya, and they enrolled neonates, and they were randomized to either receive standard of care with ampicillin and gentamicin for suspected sepsis, or they receive standard of care as well as fosfomycin. They dosed the fosfomycin as per the product information, which is 100 milligram per kilo, 12 hourly, and the participants received at least 48 hours of IV fosfomycin, and if they were tolerating oral, would be swapped over to an oral suspension at the same dose. And from this study, they obtained 238 plasma PK samples. So each participant had 4 samples done, 2 whilst on IV and 2 whilst on oral therapy. And they also obtained 15 opportunistic CSF samples. And so this is just a table with their key results. So their POP-PK model was a 2-compartment model with an additional CSF compartment. And they showed a bioavailability of 0.478, which is pretty similar to the adult bioavailability of just over 0.5. And they also had a CSF to plasma ratio, which was 0.32. And so this is exciting data for, a possible new antimicrobial in the neonatal age group, given the antimicrobial resistance we're seeing against current antimicrobials. So that's the end of my talk. Thank you very much for having me. And these are just some acknowledgements mainly to the people that have been involved in my PhD and our clinical trial. Thanks very much.
Thank you very much, Amanda. Really appreciate your presentation. And thanks to all of our panelists. We've got quite a few questions in our Q&A, which we'll run through them now. I'm going to kick off with one for Tony. And so Tony, I'm wondering, have you ever encountered a patient scenario where you couldn't achieve target exposure?